All right, fantastic. Yeah, this is a little bit of switching gears. So I'm super excited to give this talk. We all use PET when it comes to comparisons and when we're tumor board. So I really made this for a group of people, some who read PET and who might not read PET, but just so we have the background. All right, the reason I made this was I found when I started reading PET a million years ago, everyone treated it as it's the answer machine. It tells us, hey, is this cancer or not? Here's a well-respected journal. This is old. But the way it started in our own literature is that this is the best test ever. Use it for any tumor ever. Just use it. And I find that people still think this. Patients look it up on Google. Our referrers know about PET-CTs. Even radiologists who don't read all the time think, gosh, what a perfect test. And so that is a problem. So what is this perfect test mentality? It's that PET is a test for cancer, period. This is FDG PET. Cancers show up positive, non-cancers don't. But it is not true. This is just radioactive sugar, and some cancers don't actually light up, okay? Now, of course, there are other things that do light up too that aren't cancer, but we're just going to talk about this middle category here. So this is the message, this is the point. Some cancers don't actually show up on FDG PET. It's something we can predict, and I think we should communicate this to people so they know what to expect. And it's essential to do so. Why? Because if other people think, hey, nothing lit up on PET, they must be cancer-free. Sometimes that's an incorrect sense of security. Maybe they don't get follow-up. Maybe a doctor doesn't follow them up. And then it makes us look bad. They'll be like, oh, this test is all these false positives, or the test missed it, or the worse, that maybe we missed it. So we want to make sure we communicate this. I have 5 categories of when FDG PET just does not work very well. I have little graphics for each of them, but we're going to go through each category together, so we don't need to read them right now. So the first one, which has this ground glass-based lesion in the lung, is hypometabolic tumors. Okay? And the classic, I know we're in GU, but my favorite example of this is one of these lung lesions. These ground glass lung lesions, they used to have this terrible name that made no sense. We now know it's a type of adenocarcinoma. These are very indolent tumors. They are hypermetabolic. They're sort of indolent, they're pre-invasive, and they don't show up for other reasons too. Not many cells, and they tend to be small, another limitation of PET. So this thing should not light up on PET. It turns out it's not only that, but there's a whole list, right? We can start reading, we can start memorizing this. They're in the lungs, they're in the abdomen, they're in the pelvis. Lots of tumors actually don't light up. Instead of memorizing this list, I'll give you some sort of guiding principles so how we can remember what are the tumors that are hypometabolic. The first is if you've learned as doctors that a certain tumor just tends to be indolent. That's a great guiding principle. We first learned about ground glass nodules and we're told, hey, this is not something that's going to kill someone immediately. We follow it for years and years and years. If you take it out, they're cured. So we expect hypometabolism because it's indolent. Most of these are just background level. What's another classic one? Thyroid. We think of this as an indolent cancer, right? Sometimes people can have it all over and it's just very, very slow. Here's a PET. There's the heart, that's fine. We see one spot, maybe 2 spots. How much cancer does this person have? It's everywhere. But we're not surprised. Very little activity because it's indolent, even though it's spread everywhere. Here's an abdomen example, right? A lymphoma infecting the stomach. If it's this indolent type of lymphoma, though, low metabolism, we know this is not super aggressive, so does not show up on PET very well. And then the classic, we just had a great lecture on prostate MRI, right? Classic in GU for hypometabolic is prostate. The reason we had a lecture on MRI and not PET is because PET does not work very well for prostate. There is a cancer in that circle. I don't know where it is. And this is why old school, we relied on other tests like bone scans to try to find some evidence of metastases, right? And this is why now there's a whole new brand new category, prostate-specific PET agents that add specificity and sensitivity. Old school, we tried to find this holy grail imaging option. Choline was first, but not that great. C11's a weird thing to use. We moved to fluciclovine at some point, and now we're in the age of PMSA-based agents. They're all getting approved somewhat recently, and really, really great tests. They will find small tumors. They're pretty specific, even if it's early. And it's because FDG is not great that we needed these kinds of tests. Other hypometabolic tumors that are also related in the abdomen, HCC is not actually super hypermetabolic, and back to GU, neither is renal cell. And not only are they not super hypermetabolic, there's a whole other problem with using PET. They are in areas of metabolism, right? The kidney gets FDG, there's metabolism in the liver, so it's hard to find. You know, if any RCC would be findable, it'd be this, right? Exophytic, outside the kidney that's concentrating FDG, and yet no, nothing in that circle. So it is just not that great of a test overall for these kinds of tumors. Maybe a little bit helpful for distant mets. You know, there is actually an RCC, we could find it, a little hypermetabolic, but the evidence not so great. A little bit good at helping us find some metastases. All right, what's another guiding principle for tumors we should expect just will not show up? One is if it's full of something that is not cells. Okay? My favorite are the ones in the lung because it's filled with air. There's definitely no cells in air, so those things should not light up. Classically, these thin-walled cysts are actually not even in the cancer category. It's usually infection. But here is a cancer that is not going to light up. There are not enough cells. Now, of course, I'm not talking about this kind of cystic lesion. Plenty of cells there. That'd be great for PET, right? And that was a cancer. So as a lung example, in the abdomen, right, here's a pancreatic-based one. This is not full of cells, right? It has low density, there are cystic structures. No matter what this is, it does not have lots of cells and should not light up. So this is unlikely to be useful, or FDG to be useful here. But of course, this is a tricky area, right? There's a spectrum of what these lesions could be. People say, hey, PET's the perfect test. It'll tell us if it's a problem or not. Let's get it. But of course, it's a cystic lesion. It's not going to have much uptake. Nothing there. And it doesn't help, right? All it has proven is that it's not super aggressive with tons of cells. We still don't know where on that spectrum it is. Lots of various malignancies don't show up. And in fact, some non-malignant things can have inflammation. So it's just not very good. And this was a neoplasm. Now, of course, if it does have lots of cells and is very aggressive, sure, that will light up. It's everything short of that, though. You know, we don't know where it is on that spectrum. And one more, here's actually retroperitoneal. Again, very low density. So this one is full of mucin, not having lots of cells. Plenty of lesions, but no real good activity. And it's because just not very many cells, right? In fact, about half do not light up. And I'll show you another mucin example. This is a really bad tumor, right? It's going through tissue planes, it's all over the liver, and despite being aggressive enough to get into the ischiorectal fossa, still no activity, despite being a very aggressive, invading malignancy. Just not enough cells. This is a bad test for it. All right, and the last guiding principle, when we can say, hey, FDG probably won't work, is if we prove the tumor is indolent, in this one patient. Here's my favorite example. Small nodule embedded in some interstitial lung disease, clearly has grown. probably was not caught to begin with. With that growth, that's cancer. That is what it is, must be. But of course, what happens? Like, oh, they have ILD, they're old, surgery will be bad. Are we sure? Let's get a PET. It tells us when things are bad. But it won't. It took 5 years to grow to that. Cannot be super hypermetabolic. It just won't. And it is super clearly a cancer. So, many tumors are hypometabolic. That's one reason FDG does not work. You can infer this without memorizing that big old list. And you should say so. This tumor is not likely to light up. All right, when is the next category when FDG is unlikely to work? Tumors that get treated. Now, sort of my whole point is that cancer can be in a patient and not show up in FDG. The counter example is where I'll start in this category, which is lymphoma. Actually, PET is very good. If that treated lymphoma has no activity, it probably does mean there's no cancer, right? Even on follow-up, no activity, no cancer. Great. Really good test for this. In fact, it is so good, we actually use post-treatment FDG PET to say your prognosis. There's categories. We use Deauville. It says your treated lymphoma. Is it higher or lower than the liver or the mediastinum? Let's throw a number on it, and the low numbers are good prognosis. So for example, here's a groin lymphoma. It has been treated. I put a measurement on it. FYI, the entire Deauville thing is supposed to be qualitative. You're not actually supposed to measure, but I think it's helpful for me. So this was a medium activity treated tumor, but it was slightly more than mediastinum, less than liver. That puts it in this medium Deauville 3, and that's actually good prognosis. So this is probably no cancer and cured. That's great. Or here, all of these retroperitoneal lymph nodes treated, no activity, Deauville 1. Great prognosis. So this is the counterexample. No activity is no cancer. But so many other tumors, that's not true. Once you treat, we don't actually know if cancer cells are still around. My favorite example is melanoma. In untreated melanoma, FDG PET's amazing. Super aggressive. You can find any MET anywhere. It's amazing. Once you treat it, though, you don't know if the live cells are still around. Now, it does say your treatment did something. At least it suppressed them or maybe treated, but does not mean they are cancer-free. So, for example, here's a fairly metastatic melanoma case. Treated, got pretty treated. Obviously, we have a couple METs still in the liver that are active, but you might say, oh, did we kill all the cancer elsewhere? And the answer is no. It was just hiding and lurking, waiting to explode at some point. It suppresses the cells, and then we can't find them anymore. And another example where that's true is esophageal, sort of an in-between case. Here's a very clear, obvious esophageal cancer, well demarcated. Once treated, complete lack of activity unfortunately does not mean they are cancer-free. Absolutely, cells might be left. This is why sometimes they then take the esophagus out, even with no activity. Now for esophageal, if we don't have activity, it means we did something with the chemo. They'll probably end up doing better overall. It doesn't mean we can maybe give them chemo again. It is technically possible we've killed them all, but we don't know for sure because treated tumors are very hard to find on FDG PET. So in the treated tumor category, sure, no uptake might mean no cancer, but only for a couple cases like lymphoma. Most tumors, actually, we just don't know if it's totally eradicated, like the two examples I gave you. There's no great rule of thumb here. We learn them case by case, but those are some of the obvious. All right, the next category where FDG PET might not be great for cancer is when the cancer is hiding, okay? And I'm using this little picture of the brain because that picture of the brain has a tumor on it. Do you see it? Do you know where it is? Is it obvious? It's not. In fact, you might guess, maybe you thought up there, and that is it. But that's pretty hard, right? There is a tumor there, but I windowed that one almost perfect for this. Usually we see the brain like this when it pops up on our PACS for a tumor board. You're not going to find the tumor there. Or here, again, a sea of background uptake, and we have a definite tumor. Do you see it? Was it obvious? Clear asymmetry? Looks sort of like a normal brain, right? But that is definitely asymmetric right there. Pretty hard to find. I mean, with arrows, it's pretty obvious, right? But it looks like brain to me. And the tumor is right there. The background of activity makes it hard. Now, do we see a tumor here? Any spot that looks weird? Yeah, that one's obvious, right? Because we don't have the background. This is why lung cancer is great for FDG PET. It's active, no background. That's a beautiful standard tumor. But it's these other areas where the difficulty shows up. And of course, this is a GU section, and tumors around urine or the kidneys are some of the biggest areas that tumors can hide. So this whole physiologic uptake or background issue, the sea of uptake hides our tumors, and I actually think there's a cognitive problem. The more you read, your brain's like, yeah, I can't see anything in the brain. Let's not look too much time. It's a waste of time. So actually, I think look less closely at these areas. So actually the trick, and I'm going to give you examples, you have to train yourself to look at the hard parts, look at the brain more, look through the kidneys better. You can also pull the PET windowing down. I'll give you an example. It makes it easier. And then we use our CT. They're all PET CTs these days, right? So for example, where's the tumor? Right? It's not obvious lung cancer this time, but there's actually a pretty big tumor there. It's right next to the kidney, which means we don't see it, right? We just think it's the kidney. This person actually had a rhabdo, is treated, some post-op mild inflammation there, big old metastasis, and your brain sort of passes over it because it's near the kidney. Now with arrows, it's a little obvious, it's big, it's round. If we did it on an axial, maybe you'll see it as pretty asymmetric. And if you pay attention, in this case we had contrast, sure, pretty obvious there's a tumor there, but it's easy if you're scrolling or looking at the MIP to miss it. And again, the GU track is a really tough area. So here is a PET only. I'm making it harder. So we're through the lower lumbar spine. You see the spine, you can see the iliac crest there. What do we think when we see a dot of activity right in front of the lumbar spine? We should think ureter, right? Ureters have urine going down in these boluses. So we usually just blow this thing off. But again, in the background activity, we have to look closer. We have to force ourselves. Window down the PET sometimes or use our CT. And here the CT really helps. That was a very tricky metastasis right next to the ureter, right? Not actually the ureter. Now here, this one where other Mets, it's not a wizard to figure out this case, but we should look closely even if it's probably physiologic. And again, in this GU tract, that's tough. So the bladder is one of the worst. Big glowing ball of activity in the pelvis, right? Where are we going to find tumor there? Well, what were our tricks? One is to window down the PET. If you don't make this overwhelmingly bright, now there's something going on, right? Something's near the bladder. We actually could have caught that on PET with the right windowing and using our CT. Clearly a tumor, super hard to find if you're scrolling fast and just use the PET. Or another bladder GU example, there's a Foley in place. We got some activity, nothing crazy looking on that picture. But if we use the CT, we window it down, that is a clearly abnormal bladder. We have a diverticulum, super thick wall. That is cancer. And would have been hard unless we used these tricks. In fact, looking for tumors in the GU tract are so bad, and you guys already knew that because you answered the question right. We don't use it to find the tumor in the bladder or find it in a ureter. We do it for things like metastases. So there's the lymph node met. That was actually the answer to our poll everywhere question. It's actually pretty good for these metastases, but not for the primary, not for a second tumor in the GU tract. So this physiologic uptake, it masks our tumors. It might cognitively make us not look closer. So we need to force ourselves. We window down PET, we use our CT. And if you can't see something, just say so. I mean, many places just say the brain has lots of activity. Who knows? Get an MR. Or if it is a bladder tumor, we just say, hey, we don't know the level of activity, not so sensitive along the track. The next case were these FDG PETs that pop up in our tumor boards and our comparisons when FDG PET does not work that well is when the tumor is small. So here I have an example of a very small pulmonary nodule. So when the tumors get increasingly small, the issue is the low resolution, right? There's a blurry surface to everything. It's sort of a blurrogram, right? But if you have a medium nodule, we have a blurry edge. And as it gets smaller and smaller and smaller, we're basically just seeing a tiny little blurred nodule. Maybe we can't even see the tiny ones. So size is an issue. Another one is motion. Our PET is one of our slowest tests, maybe right up there with MR. People are breathing, people are moving. It takes time to get enough counts. So in the breathing or the bowels moving or people shifting, we can have motion. Here's a breathing example. It affects the lung and everything below the diaphragm. This is the same person, same day. That is how much they could choose to move their diaphragm if they want. So a nodule above or below, instead of being a dot like there, actually could turn into a very blurry bar. That will make it hard to find tumors. The next technical limitation is correction. I mean, no topic gets people going like physics, so I'm not going to dive into the physics of it, but you actually do a lot of processing behind the scenes for PET, and it can make it hard to find tumors. The biggest one we do, and I don't know if you know this, but these PETs that we look at are totally corrected images. A standard PET off the scanner looks like this. The photons of the brain, really bright, and they get out easily, no blocking. But the photons of the pelvis, they got to get through all this bone and muscle and fat, and so we lose the photons. Our PETs actually come off the scanner like a little bit unreadable. So we need some way, these days it's CT, to sort of correct and say, where are our photons getting blocked? And let's fix to make a smooth, readable image that actually shows organs, and every part is similarly bright and not bright. So that's a corrected, readable image. We do this in all of them. We need to, it's great, but it's a problem if the person moves. So here, the PET was acquired where the head was tilted, CT not. Now the algorithm goes crazy. The scanner sees the activity and says, wow, there's nothing there blocking my photons. I don't need to fix this part. But look how this hemisphere is in the middle. All kinds of stuff blocking my photons. I got to really fix that. This fixing algorithm is wrong because the CT is in a different position and our fixed image is now bad. We just gave this person a frontal infarct they don't have. And if they have a tumor in that fake frontal infarct, it's also not going to be very bright. So this correction mechanism can mess up our intensity and our sensitivity, and so can the second. Now this one's even more complicated. I won't get into how it happens, but there's this thing where they try to correct for scattering photons. It works great, except when there's motion. So with the same PET CT, person's arms on the side versus the front, that amount of big motion between meant this scatter went crazy. That is why there's this big ball of no photons in the middle. We will miss tumors there. It's actually something you can correct. You can just say, well, don't do that scatter, and then it looks fine again. So we have technical limitations. They happen. I just gave you some clear examples. You can read through it. You can try to fix it like that scatter example, or just report it. This is a limitation. All right, and the last one. When does FDG PET not work great? When the patient was not prepared. And what does that mean? We do not want them to have tons of insulin or tons of glucose. So why is insulin a problem? Insulin will happen for non-diabetics by just eating, but of course you could inject insulin. And the issue is it takes all of our FDG. We want it to go to the tumor, and instead it is driven into the muscles by the insulin. And this is the classic hyperinsulin-looking FDG PET image. Active muscles, hard to see everything else. And it's everywhere, right? So what do we do? When patients come for these PET scans, whether you read them or they're your comparisons, the tech is asking them if they eat. And as is true in all of life, the biggest enemy is carbs, right? I don't actually care about sugar-free gum, but if you're having a baguette from Frenchland and Epcot, it's a problem. Now, if they are ingesting lots of carbs, they ate, we don't scan them or we wait, and we try not to have short-acting insulin. And you can see in axials, they're actually pretty bad pictures. We could still actually see the tumors in this abdominal case. It's a pancreatic case, but still not a great image. So we would say, hey, the SUVs we're measuring are probably low. We might miss some. Maybe we should do it again. And too much glucose is very similar. The issue here is you might not know or remember, but glucose needs a transporter to get in our cells. It's not actually passive. So if you have tons of glucose in your bloodstream, our radioactive glucose competes. And the classic picture is this: huge, blobby, unreadable PET. Okay? I don't even know where the organs are, much less if there's a tumor. So we also check patients for their blood glucose level. We have cutoffs that are individualized for each place, and if it's too high, we don't scan them. So this one obviously happened, right? We need a little QA process, like, what's the deal? This is an old case. I don't remember what happened. I think they didn't measure, obviously. So if it happens and you're stuck, no SUVs here are going to be right. We're probably not going to find tumors. And this one's terrible. Probably needs to be repeated. And here you can see 3 examples of too much glucose, all the same. It's a blobby picture. The axial is terrible. The brain's not very active. Too much glucose. So here, hyperinsulinemia is your muscles are active. Hyperglycemia, the pictures look terrible. I think if it looks just unreadable, it's probably unreadable, and I don't put an SUV on things. If it looks okay, even though the number was high and we scanned, I just say maybe the SUV is wrong. All right, so those are the 5 areas. And I'd like to point out, first here, we're in the GU section. We just went over prostate. There are prostate-specific tracers. There's actually neuroendocrine tracers. This line of thought is true for other tracers. If you have a tumor at the spot that gets physiologic activity, hard to find. But the prep, the patient issues with each individual tracer is different based on the chemistry, right? And then I like to end with sort of 2 parting thoughts. The first is to be clear. People do not get this. FDG PET sometimes is bad. So I say things like, despite the low activity, I still think it's a cancer. So people aren't confused. Or I said PET is not good for transitional cell carcinoma. Now, who has time these days? Nobody. But if you can, and you can call people and sort of build trust around this, you could explain how this works. And my other big parting thought, we just had a whole lecture on when we think FDG PET will not work well. If you have an indolent tumor and you're expecting low metabolism, but it's actually high, then something weird's going on, right? Maybe it's something else that's not a tumor, maybe it's a different cancer, or maybe it's a version of this cancer that de-differentiated. So, the main message here, thanks for sticking out for this last lecture, some tumors will not show up on FDG PET. It is something you can now predict like experts, and we should communicate this so people know how good the test is or is not. And that is it. Thank you very much.